Hello, my name is Jenna Meredith, and I'm a student neonatal nurse practitioner at East Carolina University's College of Nursing. Today we will be discussing a standardized slow enteral feeding protocol in the incidence of necrotizing enterocolitis in extremely low birth weight infants by Dr. Viswanathan and his colleagues from Metro Health Medical Center in Cleveland, Ohio. Necrotizing enterocolitis is a devastating disease that preterm infants face where portions of the intestine actually die. The authors hoped that by implementing a standardized slow feeding protocol that perhaps they could help reduce the incidence of this occurring. Necrotizing enterocolitis, or NEC, is a significant cause of mortality and morbidity in extremely preterm infants. Compared with early enteral feedings, the delayed introduction and slow advancement of enteral feedings to reduce the incidence of NEC is not well studied in extremely low birth weight infants. Dr. Viswanathan and his colleagues aim to study the effects of a standardized slow enteral feeding protocol in extremely low birth weight infants. The increased use of human breast milk and the implementation of standardized feeding protocols have helped to reduce the incidence of NEC. In units where preterm formula is used when breast milk is not available, whether it be maternal or donor, this study has shown a way to sustain the reduction of NEC by slower standardized enteral feeding advancements, especially in babies with birth weights of less than 750 grams, which is the group that has the highest risk of dying from NEC. The pathophysiology of necrotizing enterocolitis is multifactorial and poorly understood. Immaturity of the intestinal tract, inappropriate response to injuries, abnormal bacterial colonization, and genetic predisposition have all been implicated in the etiology of NEC. In addition to short-term complications such as feeding intolerance, intestinal obstruction, and short gut syndrome, surviving infants, particularly those with surgical NEC, have poor neurodevelopmental outcomes and represent a huge financial burden to the healthcare system. The question that Dr. Viswanathan and his colleagues ask is, does a standardized slow enteral feeding, SSEF, protocol affect the development of NEC? NEC is obviously a devastating illness, especially in extremely low birth weight infants. These infants have a birth weight of less than 1,000 grams. In very low birth weight infants with a birth weight of less than 1,500 grams, the mean incidence of NEC ranges from 7 to 9% with an estimated fatality rate of 15 to 30%, and the greatest mortality in infants requiring surgery for NEC. In the most recently published Eunice Kennedy Shriver National Institute of Child Health and Human Development Research Network outcome data, the incidence of NEC was 11% for preterm infants born at less than 28 weeks gestation. This study is significant to the field of neonatology and to healthcare professionals working in a neonatal intensive care unit because little progress has been made in the management of NEC once it occurs. The authors explain that preventative strategies are more likely to have a greater impact in reducing the mortality and morbidity from NEC. Dr. Viswanathan and his colleagues do not identify any specific literature review. They do, however, take the time to discuss several studies pertinent to their own. They looked at epidemiological studies which have found that compared with non-Hispanic white infants, non-Hispanic black infants have a higher incidence of NEC. In addition, the incidence of NEC is also reported to be higher in male infants. The authors mention one study by Holman and colleagues that describes the trends and risk factors for infant mortality in the United States and showed that the death from NEC was highest in very low birth weight infants who were black and male. The demographic characteristics of the infants in Dr. Viswanathan and colleagues' study have a higher proportion of black male infants and represent a group at particularly high risk for developing NEC. Next, the authors discuss observational data and studies. Observational data suggests that delaying the introduction of enteral feeds until 5 to 10 days postnatally reduces the risk of NEC in very low birth weight infants. However, prolonged NPO, or nothing by mouth, status may cause atrophy of the intestinal mucosa, delayed development of absorptive function, decreased motility, and development of pro-inflammatory changes. In various observational studies, infants who received early trophic feeds were reported to have better feeding tolerance, improved growth, reduced length of hospitalization, and decreased likelihood of sepsis compared with infants who received delayed enteral feeds. However, these potential short-term benefits of early enteral feeds were not shown to demonstrate a difference in preventing NEC. A meta-analysis of 9 randomized control trials did not find a significant difference in NEC rate, time to regain birth weight, time to reach full enteral feeds, incidence of invasive infections, duration of hospital stay, or all-cause mortality between early trophic feed and enteral fasting, which was defined as NPO for 5 days. In a recently reported multi-center randomized control trial, the incidence of NEC and surgical NEC in preterm infants with a birth weight of less than 1,250 grams, who were exclusively fed human milk, were 5.8% and 1.4%, compared with 15.9% and 10.1% in infants who were fed human milk supplemented with bovine milk-based products. A meta-analysis of studies comparing donor breast milk and formula demonstrated that preterm infants fed with formula had more than twice the odds of NEC compared with infants fed donor breast milk. However, these studies included only a minority of extremely preterm infants, and the effects of donor breast milk combined with human milk fortifier were not evaluated. In a population-based cohort study of extremely low birth weight infants, NEC occurred at a mean postnatal age of 32 days, similar to Dr. Viswanathan and colleagues' controls. The nearly doubled time to the onset of NEC in the SEF group suggests that delaying the establishment of enteral feeds also delays the onset of NEC. Sullivan and colleagues studied infants of less than or equal to 1,250 grams, and the combined outcome of NEC and death was significantly less common in infants exclusively fed human milk compared with human milk supplemented with a bovine milk-based product. Dr. Viswanathan and his colleagues carried out a prospective study in a cohort of extremely low birth weight infants who followed the SSEF protocol and compared the short-term outcomes with a historical control group of extremely low birth weight infants admitted to the same neonatal intensive care unit prior to the implementation of the SSEF protocol. In order to be included in this study, infants who were extremely low birth weight and less than 30 weeks of gestational age and were admitted to the Metro Health Medical Center NICU between September 2009 and December of 2012 were placed in the SSEF and prospective cohort group. They were then compared with the historical control group, which were extremely low birth weight infants of less than or equal to 30 weeks gestation, also admitted to Metro Health Medical Center NICU, but between January of 2003 and July of 2009. The researchers excluded infants with major anomalies, known gastrointestinal anomalies, operative diagnosis of spontaneous intestinal perforation, as well as infants who NEC and died before the initiation of feeds. Also excluded were infants who were transferred to another facility before reaching full enteral feeds. In regards to statistical analysis, based on the historical data, the incidence of NEC in extremely low birth weight infants was 11% at the study initiation based on Metro Health Medical Center NICU statistics. The researchers determined that a prospective group sample size of 125 extremely low birth weight infants compared with 30 controls would have 80% power to detect a decrease in the incidence of NEC to 3.3% using a two-tailed 95% confidence interval. The authors performed an appropriate bivariate analysis to identify the unadjusted differences between the SSEF group and historical controls. A p-value of less than 0.05 was considered statistically significant. The authors also performed a propensity score analysis to calculate the adjusted SSEF group effect compared with controls on various outcomes. This will be discussed further. Using multiple logistic regression, the authors calculated a PS, or propensity score, for entering the SSEF group for each infant. Analysis using one-to-one greedy PS matching stratified by birth weight group, as well as PS weighting by the inverse PS to calculate the mean intervention if performed. Conditional logistic regression and paired t-test and survey design were performed based on the PS matched and weighted pairs, as well as direct PS adjusted comparisons of the SSEF group to the controls on NEC and other secondary outcomes. Statistical software R version R-2.14.1 was used for statistical analysis of the data. The propensity score was used in this study. Selection bias is a big issue with observational studies. If the baseline characteristics of the control group is different from the case group, that will affect the outcome analysis. The usual method is to adjust for these baseline differences by regression methods. PS analysis represents an improvement over these traditional modeling strategies commonly used in observational studies. Propensity score matching attempts to reduce the bias due to confounding baseline variables that could be found in an estimate of the treatment effect obtained from simply comparing outcomes among units that received the treatment versus those that did not. Here in this study, infants in the SSEF group are matched on a range of potentially confounding factors to control infants. The two groups can be considered equivalent to each other if no statistical difference exists between the groups on all the covariates included in the model. The two PS matched groups are then compared to each other on various outcomes. Thus, PS analysis represents a quasi-randomized control design using observational data. The SSEF group in this study had a mean PS score of 0.36 plus or minus 0.12, whereas the control group had a mean PS of 0.27 plus or minus 0.5, making the p-value less than 0.001. In both the PS matched groups and PS weighted groups, all the covariates included in the model were well balanced. The PS adjusted all-cause death and combined NEC and death rates were significantly lower in the SSEF group compared with the control. Moving on to results, during the control study period, 391 extremely low birth weight infants were admitted to the Metro Health Medical Center NICU. A total of 97 infants met the exclusion criteria. During the SSEF study period, 145 extremely low birth weight infants were admitted to the Metro Health Medical Center NICU, and 20 of them met exclusion criteria. The final study sample consisted of 294 infants in the control group and 125 infants in the SSEF group. The overall incidence of NEC and surgical NEC were not significantly different between the SSEF group and controls. However, in infants with a birth weight of less than 750 grams, there was a significant reduction in NEC with a p-value of less than 0.01 in the SSEF group compared with the controls. No infants with birth weights of less than 750 grams in the SSEF group developed surgical NEC compared with 7-8% in the controls. The timing of NEC onset was significantly delayed in the SSEF group compared with the controls. The SSEF group also required significantly more total central line days compared with the controls. The incidence of culture-positive sepsis was not significantly different between the two groups, but infants in the SSEF group developed infections later in their NICU stay and were exposed to a longer duration of antibiotics. The SSEF group had significantly higher alkaline phosphatase levels with no difference in the incidence of cholestasis compared with the controls. The SSEF group also had less chronic lung disease, hypotension requiring inotropic meds, PDA ligation, and ROP laser surgery compared with the controls. In the infants who survived to NICU discharge, the SSEF group had significantly greater body weight with a similar length of NICU stay compared with the controls. Since there were significant differences in comorbidities between the SSEF and control groups that may be potentially associated with death, an additional logistic regression was performed to determine the adjusted SSEF group effect on the combined NEC and death outcome using all the covariates potentially related to combined NEC and death, with a p-value of less than or equal to the unadjusted analysis, which included total antibiotic days, cholestasis, peak alkaline phosphatase levels, total central line days, chronic lung disease, inotropic medication use, PDA ligation, and ROP laser surgery. When controlling for these factors, being in the SSEF group was independently associated with a significant reduction in combined NEC and death. There were definitely limitations in this study. Only about 1/3 of the infants remained on human milk at full enteral feeds in spite of higher rate of human milk initiation. The authors' results were not isolated, as one study reported that only 30% of mothers were able to supply 100% of their extremely premature infants' needs. This suggests that the outcomes of this study are not generalizable to the population fed mainly with a human milk diet. Since this study spans more than a decade, it's possible that practice changes in the care of extremely low birth weight infants have affected the outcomes reported. For example, more medical treatments of PDA compared with primary PDA ligation and earlier extubation, as well as aggressive non-invasive ventilation in the SSEF group reflect current neonatal practice. Also, the authors have reported only the short-term outcomes associated with the SSEF protocol, as the study was not designed to assess the long-term neurodevelopmental outcomes. This information could definitely be incorporated into current clinical practice. As the study was carried out at my current institution, we have already instituted this SSEF protocol in place. NEC has high morbidity and mortality. This study demonstrates that when using human milk or preterm formula, following an SSEF protocol helps to reduce NEC and combined NEC and death rates in infants with a birth weight of less than 750 grams. As discussed previously, although there are potential short-term benefits of early enteral feedings, they were not shown to demonstrate a difference in preventing NEC. In addition, although it takes infants longer to achieve full feedings with the SSEF protocol, surviving extremely low birth weight infants demonstrated comparable weight gain at discharge without prolonging their hospital stay. In conclusion, this study shows that an SSEF protocol could be beneficial in infants whose birth weight was less than 750 grams. A reduction in NEC rates in infants with a birth weight of less than 750 grams from 16.2% to 2.1% is huge. The authors feel that reducing the combined NEC and death rate outweighs the potential nutrition-related harm associated with the delayed initiation and slower advancement of enteral feedings, especially when using formula as the initiation milk. The authors suggest that because the etiology of NEC is multifactorial, only adequately powered, vigorously conducted randomized trials with sufficient follow-up can conclusively assess the rate of slow feeding advancement on NEC and other related short and long-term outcomes in extremely low birth weight infants. This study should be considered in institutions currently experiencing increased rates of NEC, as well as those institutions currently feeding infants sooner than suggested by Dr. Viswanathan and colleagues. Thank you very much for your time.